Welcome, everyone. I'm Robert Klitzman. I am a professor of psychiatry and the director of the Masters of Bioethics program here at Columbia University. And we're delighted to have you join us for what should be a fascinating webinar on the ethics of telemental health: challenges, dilemmas, and opportunities. We have three fabulous speakers who are all experts in this area and have written and commented widely on these issues. And I'll be introducing them in a moment. I want to say that this is a collaboration between the Masters of Bioethics program and the Department of Psychiatry Continuing Education Department. So we will be offering continuing education credits for psychologists, and if you're here at Columbia, for social workers as well, and we'll be putting information about that into the chat. We see this as a very interactive session, so please feel free to ask questions at any point in the Q&A box, and hopefully we'll have a chance to answer as many questions as possible. As I mentioned, we have three wonderful speakers. The first to speak will be Dr. Manuel Trexel. He is the head of the Clinical Ethics Unit at the University Hospital Basel and the University Psychiatric Clinics Basel. And he is a lecturer at the medical faculty of the University of Basel in Switzerland. He has been trained in medicine, also has a PhD in psychology and a master's in philosophy. He has written and spoken widely about these and other issues, and he was recently awarded the Mark S. Ehrenreich Global Prize in Healthcare Ethics from the University of Southern California. Speaking second will be Katie Skimming. She is a forensic psychiatrist at the Mid-Hudson Forensic Psychiatric Center here in New York State. She completed her forensic psychiatry fellowship at Columbia Cornell and continues to work with fellows at Mid-Hudson. She also earned a master's in bioethics from NYU. And last but not least, Dr. Paul Applebaum is the Elizabeth K. Dollard Professor of Psychiatry, Medicine, and Law, and the Director of the Division of Law, Psychiatry, and Ethics at Columbia. He was previously the chairman of the Department of Psychiatry at the University of Massachusetts Medical School. He's also been a past president of the American Psychiatric Association, the American Academy of Psychiatry and Law, and the Massachusetts Psychiatric Society. He is chair of the DSM Steering Committee for the APA and of the Standing Committee of Ethics for the World Psychiatric Association. We're delighted to have all three, and without further ado, Dr. Trexel, welcome and thank you.
Thank you very much for inviting me. I hope everybody can see my slides now.
Yes.
I will start and introduce you in the topic of telepsychiatry and online psychotherapies. I will mostly speak about pros and cons, so say ethical pros and cons for or against online psychotherapy. Here I use the term online psychotherapy very broadly in the sense of describing psychotherapy delivered remotely using some form of communication technology, also described as internet therapy, e-therapy, or cyber therapy. Historically, since the late 1990s, a growing body of research has addressed issues related to online psychotherapy. And since then, psychotherapy over distance using technology is a rapidly growing practice, reaching many patients. Particularly, an increased use has been observed during the COVID-19 pandemic, and now it's still a growing field. And I think, therefore, the risks and benefits need to be known by all psychotherapists and also all psychiatrists, whether they themselves practice online or not. What I say today is mainly built on two publications. First, this is a book chapter in the Oxford Handbook of Psychotherapy Ethics, and another publication. This is a narrative review article in the Journal of Frontiers in Psychiatry. For this publication, we have conducted a comprehensive review of the main ethical arguments for and against different forms of online psychotherapy, which aims to enhance discussion of ethical issues in this growing area. I will not talk much on the methods for this review. If you're interested, I have some slides at the end of my presentation, but I would like to directly jump to the the top 5 ethical arguments mentioned in favor of online psychotherapy in all these publications. It's first, increased access and availability and flexibility. That was one of the top pro arguments. Number 2 was therapy benefits and enhancement in communication. The third pro argument was client characteristics. The fourth argument, convenience, satisfaction, acceptance, and increased demand. And the number 5 was economic advantages. I can say more about these later in the discussion, if you like. For now, just I let it like a list. So, and the top 5 arguments against online psychotherapy were mentioned: privacy, confidentiality, and security issues as the first contra argument. Number 2 was therapist competence and training. Number 3 was communication issues. Number 4 was research gaps, and number 5, emergency issues. About the emergency issues, Paul Applebaum will tell you more later. I would like to focus first on the privacy, confidentiality, and security issues. So the privacy issue is mostly mentioned in the sense that patients are, for example, at home, but they can also be at work, even in public spaces, while doing online psychotherapy with their psychotherapists. And of course, privacy is an issue. There might be other persons at home, there might be people at work listening, there might be people in public spaces listening, and the privacy issue is a very important one. Then the confidentiality issue is related to the privacy issue, but it's not exactly the same. Confidentiality is, for example, a problem in online therapy when you think about data security, which may be compromised when using different forms of technology. And also security issues. There we talk about unsecured websites or unencrypted communication tools, which are still used for online psychotherapy. So there is another fascinating technology coming up. It's psychotherapy bots. So not robots, but like conversational artificial intelligent tools, which can be used as psychotherapy bots. And I, for this issue, I asked ChatGPT some days ago, dear ChatGPT, what are the ethical aspects of psychotherapy bots? And the answer was the following. I will not read everything to you now, but interestingly, the same issues came up as which we also found in our review: informed consent issues, privacy and confidentiality issues, the competence and training issue, the user autonomy, then emergency situations, cultural sensitivity and bias, oversight and accountability, scope of practice, long-term effects, and equity and accessibility. So more or less, these were the same issues, ethical aspects of psychotherapy bots we also found in our review of arguments for and against online psychotherapy. What ChatGPT didn't mention was these questions here, which I also find quite important and and interesting. For example, is it ethically problematic if a bot shows human-like features such as empathy? Or is it ethically problematic if patients are no longer able to differentiate if they are talking to a human or to a bot? So more or less, this is the Turing test. If whether people are able to see if it's a machine or a human. And also based on these questions, another question arises: is a psychotherapy bot an artificial intelligent psychotherapy program or system? Should it be a tool, or is it even an agent? Are bots equal partners in a conversation? And what do we do if psychotherapy bots fail? Who is responsible? Is it the bot? Is it the user? Is it the person who wrote the bot? Is it the person or the group of persons who trained the bot? These are all unsolved problems. Therapeutic tool or agent, I also asked ChatGPT about this. Are psychotherapy bots equal partners in a conversation? Are they agents? Are they human-like? Do they have human-like features? And ChatGPT answered, psychotherapy bots are not equal partners in a conversation in the same way that humans are. While they may be designed to stimulate conversation and provide support, they lack the depth of understanding, empathy, and nuanced responsiveness that human therapists bring to the therapeutic relationship. That was the answer 3 days ago. So this was the short overview. Of course, we can delve into different arguments, ethical arguments later in the discussion, but let's see what Katie and Paul have to say now. Thanks.
Great. Well, thank you, Manuel. And next, Katie.
Great. Thanks, Manuel, for starting us off. So I am going to continue the conversation of ethics in telepsychiatry. So focusing on human interactions, but I think there are overlaps in the issues that we're talking about as well, too. And how I like to kind of frame the topic for me about telepsychiatry and then thinking about it going into the psychotherapy bots is how can we as clinicians or as a field aim to provide similar quality service, similar quality treatment to that of the traditional face-to-face encounters that we have had for years. And I like to think of this as the framework of the ethical principles that we know. So talking about beneficence and non-maleficence, and I'll be talking a little bit more about kind of competent care, making sure that we're providing safe and effective care, autonomy, and that's more that I'll be talking about in the lens of patient preferences, clinician preferences, and that can be on different types of modalities or time, place, just flexibilities that we can have with autonomy that the virtual world might give us. And then also justice. I'll be talking a little bit about cost and insurance and distributed justice and access to care too. So when I think about competence, I think about that, like I said, in the realm of kind of beneficence and non-maleficence and ethics, and making sure that clinicians are appropriately trained and qualified to deliver the treatment that they're giving in that specific modality and to that right patient or person. There are different guidelines and resource documents that can help to ensure that people are providing safe and quality care. Both the Psychiatric Association, Psychological Association, Telemedicine, and the Academy of Child and Adolescents all have really great and helpful resource documents if you're interested in that, and they can touch on some ethical aspects as well too. But one of the things that I think is really interesting too, as someone that teaches and works with trainees, is how are we training our future clinicians to practice in this digital world? And it's surprising, maybe not so surprising actually, that it's a lot of the same skills that you can learn through telehealth, telepsychiatry, mental health is what we are trained to do to become competent clinicians in a face-to-face encounter. And there might be some changes to that or nuances that we need to adapt to, but this one study kind of looked at the key aspects in training for tele-mental health, and it really focused on the technical skills, assessment, doing a good clinical exam, relational and communication skills, collaborative and interpersonal, administrative, medical, legal, community psychiatry, and cultural psychiatry. And these are all aspects that we look for in our training and things. And I think still kind of that core of what we would want our clinical practice to be, whether it's face-to-face or a telehealth encounter as well too. So I think it's good to set that framework where you are kind of continuing that same foundation, good foundation, and just adapting it to the different modality, different time, different situation that we might be faced in. And I think that is where your ethical principles can help to guide you as well. And one of the papers that I worked on really focused a lot on kind of matching the modality to the patient and the clinical situation too, that's also a key factor, is having the ability to know the limitations, but also the benefits of certain modalities for certain patients too. And that can be a variety of things, whether that's location, if the patient is at home or in their work, they need flexibility, or if they're located in a different clinical site, whether that's a clinical office, hospital, emergency department, matching the complexity of the patient. Is a patient too acute, or are there issues that need to be more closely monitored with labs or vitals that are outside the scope? But then also looking at preference too, because as I'll look at later, that can be a key for choosing if telehealth is right for that patient as well. And then just overall telehealth in general, there are benefits to it, and looking at improved outcomes, preferred modality, ease of use, low cost, and improved communication. And this is in telehealth in general, but if we look at telepsychiatry, a lot of those themes actually do stand as well. And some of the research points to when telehealth is most effective really relies on the patient and clinician satisfaction, and making sure that the technology is adequate to facilitate the important aspects of the clinical exam or treatment. And again, it's kind of that matching the patient and to the right modality as well. And overall, it seems that patients and clinicians generally are satisfied with telepsychiatry, and the outcomes show that it is comparable in efficacy to face-to-face in terms of clinical assessments and treatment outcomes. There's been randomized controlled trials looking at depression, PTSD, ADHD, bulimia nervosa, and it looks at the outcomes based on standard scores like the PHQ-9, I think a PCL, and different efficacy measures. And there are some limitations with this study, but overall it's showing that telehealth in particular telemental health, can be effective, if not more effective, as in person. And as Manuel also talked about some concerns too, this research study kind of highlighted that providers do tend to express more concern about potential adverse effects on rapport with patients. And I think that's something that I've seen myself in clinical practice, where as patients maybe aren't as aware or don't see it as being as much of a problem, but it's still kind of this change, this angst that clinicians are facing, adapting to a different modality. And so that's one of the things I did want to talk about too, because if we're talking about competent care, effective care, not everything has been studied yet. We're still fairly new into that. And one of the things particularly focused on therapy that I've had in conversations with other providers, but haven't really seen in the literature. So if someone has this literature or just firsthand experience, I'd be curious about your own experiences. But there's a definite change in the therapeutic dynamics when going face to face versus virtual, and how much of a change does that really matter? The studies might show that it's not a significant difference, or maybe even a better difference. But then going into the satisfaction, there might be these nuances that we're not necessarily capturing. And so kind of what are the actual changes to competent care that we're giving if we're entering a patient's environment, if that's home, work. I've seen patients in their cars as well. And with that, you're getting more information than you might have, or maybe earlier information that you might have about the patient. How is that affecting the dynamics in the therapy? There's also the potential for sessions outside of typical office hours, right? One of the highlights of telehealth is that you're not confined to the typical office, and so patients might want to see appointments after hours when they're home, and what kind of changes that might have to the therapeutic frame. There's also potential for changes if it's just an audio only session. I'll get to this too, but not only not having the video and seeing someone's face and the body language, but just having those audio sessions. Is that more like a telephone conversation that you would have with a friend rather than a therapeutic session? And now I'm sure you've seen too that there's these online organizations that are offering text only as the therapy modality too. And how does that change? Does that affect the therapy and treatment that we're giving? And then one of the other things is that there's, I don't know about studies, but significant, just my own experience is that time after a therapeutic session that a patient will spend immediately after the therapy or in between sessions, and how much of that is actually lost if a person is just returning back to work immediately, or going into the other room and returning to their children, their family, and resuming those responsibilities. Doesn't give you as much of the same time and space to work on all of those issues that you were just discussing in therapy. And then does this kind of diminish the therapeutic benefits? Are we sliding into more of a social rather than a therapeutic frame? And I think that's where it would be super helpful if people have just different ways that they can maintain the therapeutic frame and that therapeutic environment, because I think that's an area that we can continue to study and look into to match that face-to-face encounter. And then also I wanted to talk about costs, and again, talking about this mostly from financial, but also there's the obvious access to see clinicians and patients that might otherwise have access to mental health services, whether that's because of geographic and rural environments, or in jails and prisons, or if a patient isn't as able to leave their home or apartment and go to the office, telehealth definitely helps with access to that. But then there's also the financial costs as well, and that can be, I think, they talk about direct costs and indirect costs. So direct costs being things like time and supplies, investment in the technology, but then those indirect costs talking about transportation and office space. And generally, it's the studies have shown that telepsychiatry is less costly than the face-to-face encounters. They're still doing research on like returns on investment, and that shows a little bit mixed. But it's also interesting that it also might depend on the location setting, that the cost savings might be better off in more rural settings than maybe in an urban setting. But one of the studies that I did want to highlight too, because I think it's interesting for people in New York, and also different than the typical maybe in home therapy environment, is that there's actually some studies that look on the cost and savings of telepsychiatry within a otherwise clinical encounter. So this one is looking at ED visits. And if telepsychiatry was offered in the ED, it actually reduced the observation services, the amount of time that someone was in the emergency department awaiting a disposition, and how that can contribute to cost savings, but then also time savings as well too. Interestingly, this is also associated with more urban settings and settings that already had psychiatric services, so that might be part of it too. But thinking more broadly of all of the different ways that telepsychiatry, telemental health can facilitate these clinical interactions is interesting and important. And then the last thing I wanted to talk to you about with regards to insurance and costs is that with the COVID-19 pandemic, we really are seeing much more parity. And again, I think that goes to the access issue, wanting people to have access to mental health treatment, but then also looking at the data on the effectiveness showing that the treatment is similarly effective, if not more effective than the face-to-face encounters. And so since the COVID-19 pandemic, the big insurance companies like the Centers for Medicare Medicaid Services, they have been reimbursing providers at the non-facility rate, so equal reimbursement for the face-to-face and the virtual encounters, and that the telehealth visits are considered as in-person visits. And interestingly, I think for psychiatry is that this does include the audio only. And this, I think, came out of a convenience if people didn't have the video. But in our field, an audio only session, what kind of differences does that pose to our field as well, too, is interesting. And again, those changes are in effect through 2024 now, and thoughts that it would probably continue on. And then states can vary by the insurance coverage that they demand, but New York State is one of those states that offers parities and requires the commercial insurance and the Medicaid to offer the same reimbursement rates. And so again, I think it's interesting to how the access for more people to have access to mental health services is being delivered. But then also with the rising healthcare costs that we have, how can we work to maximize the services that we can provide with the theoretically limited amount of money that we can pay for those services has been interesting too. And this is how so far we've been managing it, but be curious to see how that continues on. So I think that's it for me for now.
Great. Well, thank you. And next, we're delighted to have Dr. Applebaum. And just a reminder, everyone, please feel free to ask questions in the Q&A, and we'll have time, hopefully, to answer as many as we can.
Okay. So, hi, everybody, and thank you, Bob, for inviting me to be part of this. So, let me tell you a little bit about the way I come to this topic. Since March 2020, essentially since the beginning of the pandemic, I have seen patients exclusively online for both purposes of psychotherapy and purposes of psychopharmacology, and for many patients, both together. I've also done multiple forensic evaluations online for such reasons as evaluation of emotional harms, work-related disability, decisional competence, etc. And my overall sense, which I think is supported by some of the studies that you've heard about already, is that this works pretty well. Both online treatment and online evaluation can, in most cases, be as effective as being there in the room with someone. But for my part of this panel, I want to highlight three areas. One with regard to licensure, a second concerning prescribing for those of you who are prescribers, and the third is how to deal with emergencies online. So first, with regard to licensure, and in each case, I want to start with the legal background and then move into the ethical and clinical challenges. As you all know, I'm sure, professional licensure in the United States is a function of the states. And in general, health professionals need to be licensed in the jurisdiction where the patient is located. Now, ordinarily, that's not an issue because the patient is located where you're located. But once we move to seeing patients online, you have the possibility of the patient being in one jurisdiction while you're in a different one, and indeed the patient being in a jurisdiction where you're not licensed to provide services. This requirement was suspended by many states during the height of the pandemic, 2020, 2021, but it's now back in force in most states. You need to check each jurisdiction specifically. And there are potential downside consequences for violating this rule. You could, in theory, be criminally prosecuted for the unauthorized practice of medicine, psychology, or whatever licensed profession you represent in the jurisdiction where the patient is located. So if I were to see a patient in Kansas where I'm not licensed, I could, in theory, be criminally prosecuted by the state of Kansas for practicing medicine in an unauthorized way. Moreover, and for many people, this is an even greater concern, malpractice insurers may not cover claims that arise from treatment rendered in a jurisdiction in which you are not licensed. So you conduct these evaluations and treatment sessions at your own risk. But of course, those general rules, as clear as they may sound, don't always mesh nicely with the realities of clinical practice. So here's a situation for you to consider. You've got a patient who you see in your jurisdiction, they live in your jurisdiction, and they go on vacation. And an urgent situation arises. Their symptoms are acutely exacerbated. They're having panic attacks. They're having a recurrence of psychotic symptomatology. They develop acute suicidal ideation. Or in a less urgent situation, you're treating a patient for a period of time. They move to another state. They agree that they'll find a new treater down there, but they're having trouble finding a new treater, and they contact you and ask if you would continue seeing them, at least for a transition period, at least to give them some time to link up with someone new down there. What do you do in either of these circumstances? Do you decline to see the patient unless they return to New York, or suggest that they find a local mental health professional? I'm sorry, there's just nothing I can do. I'm not licensed there. Do you see the patient once, but perhaps only to assess whether the condition is an emergent one, and if so, to refer them to a local emergency service wherever they may be? Or do you see the patient as much as you need to while they're on vacation or in this transition period in order to stabilize them and make sure that they're okay until they get back or until they link up with a local treater. Well, declining to see the patient at all, and I'm aware of people who have done this, certainly conforms with the law of licensure. On the other hand, it would appear to neglect the duty of beneficence that we have towards our patients. That is, the duty to benefit them, to do good for them, to take care of them in an ongoing way. On the other hand, if you see the patient, although it discharges your ethical obligation of beneficence, it leaves you open potentially to prosecution and an undefended lawsuit should something go wrong. How would I balance those concerns? Well, frankly, the risk of prosecution in a circumstance where a patient's on vacation and contacts you for a single session or 2 sessions while they're in some other state seems really slim. I'm not saying that it's impossible. It just doesn't seem all that likely. If I had a patient who was in an urgent situation, I think I'd be willing to take the low risk of a malpractice claim arising from that contact, rather than abandoning the patient and saying, I'm sorry, unless you get in your car and drive back to New York, I can't help. But your risk manager may have a very different view of this and may want to balance things more on the side of legal protection and compliance with licensure rules than on the side of beneficence towards your patient. So you should certainly find out what your facility's position on these issues is if you work in a facility. What about prescribing? So the legal background is that authorization for prescribing is limited to jurisdictions where you're licensed if you're a prescriber. Although our electronic prescribing systems these days make it possible for me or you to send a prescription anywhere in the United States, to any pharmacy in the United States. Prescription of controlled substances, we're not talking about opiates here, we're talking about Klonopin, Ambien, medications that are frequently prescribed to psychiatric patients, requires Drug Enforcement Administration registration in that jurisdiction and conceivably in multiple jurisdictions, although this requirement was suspended during the pandemic, and the suspension will continue through 2024. And there are sanctions for not complying with these rules, including prosecution, suspension of your DEA certificate and authorization to prescribe controlled substances, and again, being uncovered by a malpractice insurer. Interestingly, pre-pandemic, the DEA rules required at least one face-to-face visit prior to prescribing a controlled substance. That was embodied in the congressional action in the Ryan-Haight Act. But those rules were suspended for the pandemic, and the suspension is now extended again through 2024. And there's good and bad here. I think it's important to recognize. The suspension of the face-to-face rule gives us the flexibility to prescribe for online patients without insisting that they come in to see us, which may be inconvenient, expensive, difficult for a disabled patient to manage, et cetera. But it also, frankly, facilitates online pill mills that prescribe, for example, off-label ketamine for unapproved indications and with dubious likelihood of efficacy. And I think we need to recognize that as much as our organizations, our professional organizations, have been arguing for the flexibility, there's a definite downside to the suspension of the rule. There are, as well, ethical concerns with remote prescribing. Medications, of course, have effects on patients' bodies. not just on their psyches. And remote evaluation of some side effects can be difficult. You can't take a patient's pulse, weigh them to see if they're gaining weight, take their blood pressure, and you may, if the camera is focused on their neck and head, be unable to see tremor, lack of balance, and other things that would be immediately apparent to you if they walked into your office. You can ask patients to take their pulse or measure their blood pressure, but those measurements, of course, may not be accurate, and you can ask patients to see their primary care physician to get more accurate readings, but patients don't always comply with those requests. And so we need to balance the risk of harm to our patients against the benefits from medication. And maybe not all medications and for not all patients should be prescribed online. So finally, I want to say something briefly about dealing with emergencies. Obviously, patients can acutely decompensate, become suicidal or homicidal during an online session. And if they were in your office, depending on where you practice, you might walk them to the emergency room or call the emergency medical service to transport them, or the police if they seem to be out of control to transport them. But what do you do if they're not in your office? What do you do if they're 1,000 miles away? Well, unless you know the patient's location and have it handy, there's really not a great deal that you can do. And so we'll talk about it in a second. That's something that you should know. Keep in mind, you can't just call 911, because if you call 911, it will connect you to the police in your jurisdiction where you are sitting right now. If you've got a patient in North Carolina or Arizona, you will need to find the contact information quickly. It's an emergency after all, for the police or EMS in that jurisdiction. And of course, if the patient is aware that you're contacting the authorities and is serious about hurting themselves or other people, they may not just sit around waiting for them to get there. It's important to anticipate these possibilities. And certainly less stable patients, recent histories of suicidality, frequent decompensations, rapid cycling bipolars are probably not good candidates for online treatment. We need to be aware that in every session, the patient's location has to be specified in case an emergency arises. Sometimes it'll be obvious. You see them, they're in their home where they always are when they meet with you, but sometimes you're going to need to ask. And having contact information for local family or friends can also be helpful in the event that you need to rely on them either to reach out to the patient or to reach out to emergency services. My experience, just to wrap up here, is that despite all these complexities, online treatment usually works pretty well. It's possible to establish a diagnosis, build a relationship, conduct therapy with patients. But I want to acknowledge, as Katie, I think, suggested, that it doesn't work for everybody. And in my experience, it may perhaps especially not work for needier patients who somehow just need to have a figure, an object in the psychodynamic sense in the room with them in order to make a connection. And as we've seen, it comes with a variety of challenges. So let me stop there. Let me take down my slides. And Bob, let me turn it back to you.
Great. Well, thank you so much for 3 fascinating and varied presentations. And thank you also to those of you who put questions in the Q&A. Please feel free to continue to do so, and we have some great questions. So first question is, with using AI and bots as a therapist, who owns the data? The patient's personal information becomes a property of the owner of the AI program and bots. So how do we protect against this possibility? Anyone want to comment on that?
I think you need to ascertain upfront what the rules of a bot service would be with regard to confidentiality. And if you were to suggest to a patient that they use a bot, say in between sessions, that has to be part of the informed consent process, where the possibility of the disclosure of their confidential information is clear to them before they engage. This is, of course, an issue with GPT and AI in general. Once you upload information to that service, you lose control over it. It is no longer confidential information, which is why, for example, NIH tells reviewers of its grants that they absolutely cannot use AI programs to help assess grant proposals.
Thank you. Manuel or Katie, do you want to comment on that?
So I have nothing to add here. I completely agree with Paul. Once you type in or give your information to the chatbot or to the ChatGPT or whatever, you don't really know what the business is behind it. And there are many chatbots on the market already, not just for real illnesses, but also for mild psychological symptoms, and you don't really know what happens with the data, and I think it's a problem.
And I would just add on, I agree with everything, but stress what Paul was talking about with the importance of true conformed consent. You know, it's different than just checking a box online, right? It actually understanding what you're checking is part of that informed consent process, and people should be aware of what their information that they're giving and who would have access to that information.
Great. So next question is about justice. Do any of the speakers have concerns about telehealth becoming the standard for care delivery, and the effect this might have on people with behavioral health needs who might be without good internet access or have low technological literacy? I'm thinking about this in terms of distributed justice and the possibility that telehealth could widen health inequity gaps rather than improve them.
Well, the tendency of our private sector driven system is always to seek the least expensive forms of care. And to the extent that telehealth turns out to be more efficient than in-person visits, one could imagine it evolving into a norm. Most people, I'm less worried about technological illiteracy in that regard, because the overwhelming proportion of people these days have internet access through their phones, if not through a computer. Elderly people may have more trouble using those devices, so it could certainly be an issue for them. But I'm a little more concerned about people who are in situations where privacy is not easily obtainable, and therefore their ability to have private sessions on their phone or on their laptop with a therapist is limited. There may be legitimate reasons why people want in-person sessions, and you know, it's my view, at the very least, that they should continue to be available when possible.
Here's another question. Has there been any increased use of telepsych in settings that would otherwise pose risks to therapists, like war settings or violent offenders in prison? The safety benefits to therapists of telehealth and the patient populations this may help them reach seems underexplored. Any comments, thoughts?
Well, yeah, go ahead, Katie.
Yeah, absolutely. I think that's one of the strong benefits of mental health and telehealth in general, is that you can have access to a clinician that isn't necessarily willing or able to go into these environments, and they can have greater access to mental health in that respect. I think, particularly, I'm in the forensic setting, and I know that's been a huge help with a lot of the jails and prisons accessing care in those settings too, where a lot of times they're in rural areas, or people are more concerned about their own safety, like was mentioned, and that has been helpful to providing health care to those patients.
And coming back to the topic of justice, it can be that with this possibility, more people who are otherwise not able to get therapy can actually get therapy if they are in prison or in extremely rural areas with a 3 hours drive to the therapist. It can be also it can also increase justice in this sense to serve people who are underserved because of geographical or other restrictions.
I just wanted to add too that I think it also, because you are serving maybe a more varied population than a clinician might have been used to, just being mindful of certain cultural or institutional, if the person is incarcerated, that there might be some things that the clinician might need to be mindful of or be curious about, that might be different than patients that they're typically used to in like a more face-to-face encounter in their region, or a tele encounter in their region too. So there's ways to go about that and be curious about it too. But if you're treating a population in a different setting than you're used to, just being mindful of that.
And telepsychiatry really got its first impetus well before the pandemic in prisons, and not for reasons of safety, but for reasons of geography, which is to say, in this country, prisons are often located in rural areas without good access to mental health services, and the only way to provide psychiatric consultation or therapy services was via telepsychiatry. And at that point, it wasn't online. There were dedicated lines that had to be put in order to enable that. But that's where our field cut its teeth in providing tele-mental health services.
Here's a question. This might be for Paul. What about a situation where the therapist is out of the state on vacation, many miles from where the patient resides?
Yeah, so that's a good question. Now, people have varying practices with regard to coverage. Some people won't get coverage unless they're leaving the country, but if they're in the country, they assume that they're contactable and don't need to have on-site coverage. But I think the considerations are exactly the same as those when the patient is out of state. If you're elsewhere, even if I'm in, so I'm going to a meeting in Florida next week. If I have a patient in New York who's having a problem, even though I'm licensed in New York, there's at least a question in my mind as to whether I can legitimately practice in New York sitting in Florida, but it may not be as big a question as the other way around, as if I'm in New York and the patient is in Florida.
So there's a question here. Would Dr. Applebaum speak a bit more about online determinations of decision-making capacity? I don't know if the person who wrote that might want to add a little bit more about if there's a specific aspect of that, or if Paul, you want to maybe wait till we get more information or have thoughts on that?
Yeah, I mean, I would just say briefly, I think it can be conducted in the same way as you would a face-to-face evaluation. And if the questioner has something in particular that they want to ask about, I would invite them to do that.
Yeah, and I can just offer a first. Oh, do you have more information?
No, but go ahead.
I can offer more of a first-hand account. So I was doing consultation liaison psychiatry at a hospital that used telepsychiatry in the hospital setting, and we would use virtual telehealth encounters to do a lot of those evaluations, particularly during COVID. And usually there would be a nurse or potentially another psychiatrist, another team member in the room, but we would able to have the virtual sessions just like you would with a face-to-face encounter too. And again, it takes a little bit more change to how you're collaborating with the other providers, like the consulting, the team that's consulting the psychiatrist, but the similar questions, similar assessments, those types of things can be done virtually for sure.
So two people ask, are there any guidelines or regulations or policies? One is to govern the practice, but another was asking, should we have any? Should we change the regulations? So any thoughts about, do we need to change the policies, regulations, guidelines we have, given where things are maybe going with telemental health?
So let me say something about guidelines. The major mental health organizations, in particular, the American Psychiatric Association and the American Psychological Association, both have produced guidelines. The APA has an older, I think 2014 resource document. American Psychological Association's document is a few years newer than that. I don't find them all that helpful. They tend to be framed in broad generalities. And if you're a clinician facing a very specific problem, despite what might have been the best efforts of your organization, I don't think they've really succeeded in providing very much guidance here. From a regulatory perspective, what would be helpful? I mean, I think the restrictions on out of jurisdiction telemental health and telemedicine in general are archaic, and that we need a better way of dealing with this. And I don't hold out great hopes for national licensure, but that would, certainly make a great deal of sense. I will point to one state that is doing something, though, that I think is very positive, and it surprised me. I had a patient who moved to Florida, and I assumed that that was the last I would see him. I advised him that he had to find somebody local there, but he had trouble finding somebody local who could see him. And he really, he was begging me, could I continue to see him? I'd seen him for quite a number of years. So I investigated the situation, and I discovered that for a very small amount of money, you can register in Florida as a telemedicine provider. You need a Florida address, but there are companies that provide you with Florida addresses for $35 a year, all on the up and up. They're authorized by the state for the purpose. And then you can legally see patients in Florida with this limited license. I couldn't see a patient in person when I was down there next week, but I could see them online as long as we weren't in the same room together. So kudos to Florida, which is not always the most progressive state in the union, but in this case, I think has done something very positive.
Well, great. So unfortunately, we're out of time, but kudos to all of our speakers for really fascinating, eye-opening presentations. And thank you to all the people who asked questions. And my understanding, we will be able to make this recording available to everyone who registered, but we'll just double check that before I say that officially, but I think that should be possible. And again, stay in touch. We have another event coming up, Ethics for Lunch, a clinical ethics case and presenter from Sloan Kettering, which will be also hybrid. If you're on campus at Columbia, you serve lunch. Otherwise, it'll be online. And thank you so much for joining us. Thank you again to our wonderful speakers, and have a great day. Take care, everyone. Bye-bye.